that. I think we're heading into a pandemic of vaccine side effects and problems.
Absolutely.
So we got a tough road ahead, Rainer.
Yeah. Let's let me quickly introduce you. You're a general practitioner with a natural science background in can't read this, genetics, advanced biology, microbiology, and biochemistry. You have treated over 7,000 COVID patients with on-label use drugs. No one died, and pretty much everyone was saved. Is that about it, or did I get something wrong?
Yeah, no, you're absolutely correct, Rana. I've been through now quite a bit more than 7,000. Those are patients that I have physically examined myself. I didn't do telephone consults with them. I've excluded those from the numbers. I've been treating patients around the world, but that figure is actually the patients that I physically examined myself. And look, people think that when you do outpatient treatment, you're seeing only the milder cases. I've seen some critically ill patients, and all of them, besides the lack of hospitalizations and deaths in my practice, I've negated the need for oxygen as well. So I don't have oxygen in my practice. I've never found the need for it. Some amazing statistics, but I think if you follow the science, you can achieve the same results.
You think of other countries where people didn't get treated, or like maybe also in your country, like didn't get treated the same way, and then died or had like serious side effects. So that's really amazing. So what is it you think? Here I see that you had the information that there's like on day 8 there can be like some allergic or autoimmune complication that causes a lot of problems.
I'll explain that to you. Look, when we started with the pandemic itself, before we got the first case in South Africa, I started to look at the information that was coming through around the world to try and figure out how I'm going to deal with this once I get the first patient in the door. And I felt it nonsensical to isolate, to not examine patients, to not understand the progression of the illness, because I think that's what's important to keep patients out of hospital. We know that we must treat early. Don't allow the patients to deteriorate in any illness. And so I took the opportunity when it started in South Africa to examine every patient. I moved out of my home, I isolated myself, I put a tent out in my parking lot so that I have the ventilation and sunlight. And I wanted to examine every patient. I wanted to understand why patients were getting to hospital so critically ill. What was leading up to that scenario? We knew in hospitals there were blood clots, there was the cytokine storm, patients were breathless, requiring ventilation and oxygen. But those were all hospital perspectives. There were no perspectives on patients presenting on an outpatient basis from the onset of the illness to the point where they got to hospital. So I wanted to fill that gap. I felt that was the bit of information that was missing from the pandemic itself. And I think that's what brought me to a realization. I inquired on every patient's symptoms, the onset of the illness. I knew that breathlessness was a problem, so I explained to every patient that if they start to notice that symptom, they must present back immediately so that I could examine them and figure out the clinical picture that we were seeing with this breathlessness. And something very strange happened. All the patients that I treated with COVID had a flu-like initial illness, and it didn't seem any different from an average viral flu. Now, there's a lot of known information out there. So I knew what a respiratory virus does. I knew how to protect myself from it. I understood the course of that illness and what I'd expected a standard respiratory virus to do. And a majority of patients had this kind of illness. Yes, we had loss of smell and taste and a few minor symptoms that seemed different for coronavirus, but everything else was the same. And in all the patients that I saw, I noticed by the 5th or 6th day of illness, they showed signs of recovery. They got their appetites back, the fever had broke, they started to feel better. But there was a subset of patients who developed breathlessness, who came back to me feeling breathless. And they presented back on the day the breathlessness started, because I had educated them prior to present back timeously. And when I looked at that breathlessness, there were a few very unusual things. The first thing I noticed was that every patient that developed breathlessness in the first wave developed that breathlessness exactly a week after their first symptom. So if a person started noticing that they're feeling unwell on a Monday, during that week, they would have the viral illness. By the end of the week, they had improved. A lot of patients had completely recovered, completely. We're engaging in sport, we're back to their usual lives. And exactly a week later, on the Monday, got up feeling fatigued. By lunchtime, we're breathless. And by the evening, we're showing signs of saturation dropping. So it was very strange that on the 8th day, you were having patients with breathlessness who, on the day before, were perfectly fine. So I knew from that point on that I'm dealing with the biphasic illness, something that has two completely different pathogenicities. So I started looking at the second part. Why was there the subset of patients who came back on the 8th day breathless? It wasn't everyone. A lot of patients recovered and had absolutely no sequelae. Now, when I looked at this group of patients, there were a few things. From the group itself, it didn't seem to have a predisposition to comorbidity. Yes, I was seeing patients slightly older that were presenting with breathlessness, but I've had patients with severe comorbidities and age that presented with this and recovered relatively quickly. I've had patients who were in their 50s, absolutely healthy, no comorbidities, and presented on the 8th day with very severe illness. So I couldn't see a pattern related to comorbidity there. And then on examination of these patients, it was unusual. Now, I've examined patients with viral pneumonias before. A viral pneumonia, just to get the ground set, a viral pneumonia is a progressive illness. It starts with an upper respiratory infection, spreads into a bronchitis, progresses into a pneumonia, and that's where the breathlessness sets in. So you can almost see the progression on a daily basis to that pneumonia. However, with these patients, they were perfectly fine the day before. So there wasn't that typical progression you'd see with a viral pneumonia. The second thing I noticed with viral pneumonias, patients are acutely ill. They have high fevers. You can see that the patient is acutely ill. Whereas with these patients, they were breathless, they were fatigued, but they weren't acutely ill. If you took a step back and examined that patient from afar, you would think that patient's perfectly fine. So it wasn't the usual typical presentation of a pneumonia. The third thing I noticed was on examination and clinical examination, these patients had no restriction to airflow. So air was entering and leaving their lungs unrestricted, unlike a pneumonia where there's a restriction to flow. And of course, these patients were breathless, but the only symptom they had with breathing was that they couldn't take a deep breath. The breathing was rapid and shallow, but there was no restriction to airflow. So they were panting. So I looked at that and I thought, well, this is definitely not a pneumonia that I'm dealing with, because these patients are presenting with something very, very different. Now, from the spread of the cases that I was seeing, there was no link to comorbidity. So whether you were diabetic or hypertensive or a cardiac patient didn't seem to play any role in the severity of the illness that started on the 8th day. Now, I must stress I divide this into two illnesses, one on the first 7 days, which is the viral phase of illness, and the second part to this, which is the hypersensitivity triggered inflammatory phase, which starts on the 8th day and promptly. So in the second phase of illness, I had to figure out what the pathology was. What was causing these patients to deteriorate, devoid of any link to comorbidity? Now, some patients on the 8th day had mild symptoms, which upon treatment subsided very easily. Others had more moderate illness starting on the 8th day, and that seemed to be prolonged. And the last subset were those that had very severe illness, and that progressed to ventilation sometimes very quickly within a day or two. Now, looking at pathology and what pathology actually would fit that kind of picture, the only thing that made sense to me was an allergic reaction to an allergen triggered on the 8th day. So a type 1 kind of hypersensitivity reaction that for some reason gets triggered on the 8th day of the illness itself. So I looked at it and tried to treat using that modality. Now, as a doctor, every patient that comes to see me is put through a clinical trial. We come to a diagnosis, but we're never sure. We put the patient on medication, and the speed to recovery is what justifies your diagnosis. If the patient recovers timeously, then your diagnosis is likely to be correct. If the patient doesn't improve timeously, then you've got to relook at your diagnosis and adjust, do the necessary tests. So speed to recovery was always the most important parameter for me to determine what was going on. Now, early on in the illness, the world was using steroids. We knew that this is a steroid-responsive illness. We are aware of the problems with using steroids too early, and especially in an infection. It can suppress your immunity and cause the infection to go uncontrolled. So there is a particular point at which steroids become vital, and I needed to make that determination. Now, seeing patients present back on the 8th day with this sudden onset of breathlessness, it gave a point in time to initiate steroids. And so with the first few patients, I initiated steroids. And it took 3 to 4 days for patients to show signs of good recovery. And the first 4 or 5 patients within a week had all recovered. These were the patients that presented back on the 8th day. From looking at that, I knew the time to recovery, the speed. It was 2 to 3 days on a dose of steroid. So understanding that this is type 1 hypersensitivity, I decided to treat as such. And so the next patient that came in was a 40-year-old female, diabetic and hypertensive and obese. And she presented to me on the 8th day with a saturation of 80%, very breathless. She was perfectly fine the day before, had a history of having a flu that started exactly a week later. So again, a very typical presentation of a sudden deterioration on the 8th day. So with this patient, I understood that the steroids are going to take 2 or 3 days to get her to feel better. But if it was a type 1 hypersensitivity reaction, then I thought the addition of an antihistamine would clarify that by giving me a quicker speed to recovery. And so I put her on a kiddies dose of promethazine, which is a first-generation antihistamine, an essential drug, an emergency medication that's sanctioned by the World Health Organization and should be in every doctor's emergency kit. So I gave her a kiddies dose of this medication and asked my staff to phone her the next day and check on her improvement. And I did this with every patient, kept in touch with them to plot the recovery. And the very next day, she was perfectly fine. Her saturations had improved to 100%. But I had just given her 1 day's worth of medication. And when you treat an allergic reaction, it's got to be suppressed till your mast cells actually calm down. If you withdraw treatment too quickly, you'll have a rebound. And that's what I expected with her. So I asked my staff to inform her that if the breathlessness comes back, she needs to report back immediately. And the following day, the breathlessness resurfaced. She came back to see me. She was started on a full course of antihistamine, and she promptly recovered. And that drew my attention to the fact that I'm dealing with a type 1 hypersensitivity reaction. Now, when you have a type 1 hypersensitivity reaction, this is old science. We all have seen people having anaphylactic kind of reactions, and we know clearly what needs to get done with that. So that is how my protocol of treatment evolved. From that patient, I was under the impression that we are not dealing with a COVID pneumonia. We are rather dealing with an allergen-instigated hypersensitivity pneumonitis. Now, if you look at those two conditions, COVID pneumonia versus hypersensitivity pneumonitis, The presentation of hypersensitivity pneumonitis is a sudden, quick onset of breathlessness without the other symptoms of a pneumonia. So the patient's not acutely ill. It is due to the exposure to an allergen which triggers the severe allergic reaction in your lung, a sudden severe allergic reaction. And that leads to the sudden onset of breathlessness. Now, on high definition CT and on X-ray, which is the standard of looking at pneumonia, these two conditions cannot be told apart. If you do a high-definition CT or an X-ray on these two patients, they look identical. You get the ground glass appearance, you get all the same markers. So you cannot tell them apart solely by X-ray or CT. So I've been under the impression from the start of this pandemic that the globe has misdiagnosed this illness as a COVID pneumonia. It is more likely to be a hypersensitivity pneumonitis from the speed to recovery of my therapeutic clinical trial. Now, looking at the mediators released when you have an allergic reaction, the four main mediators that get released in any allergic reaction are histamines, leukotrienes, prostaglandins, and platelet activating factor. So my protocol of treatment followed that very early on. To the antihistamines, I added montelukast to deal with the leukotrienes. I added platelet activating, for platelet activating factor, I added an anticoagulant. It was aspirin or clopidogrel added to those who are already on aspirin. So the anticoagulation was well documented and I needed to address that. And so from the very start with using this modality of treatment, I saw great results. The dose of steroid, if you're treating a pneumonia, you've got to be very cautious. However, if you're treating a hypersensitivity pneumonitis, the high dose of the steroid is vitally important. You have to turn the reaction around before it spirals out of control. So in the first wave itself, with all the patients that I'd seen, I had improvement in oxygen saturations or improvements in hypoxia within a day. It was actually within hours that I saw patients' oxygen levels returning. So I knew from that point that I'm dealing with a hypersensitivity pneumonitis triggered by an allergen. This was too sudden an onset of the second phase to be anything else. There was no progression. And if not treated on the 8th day, it relatively quickly would spiral out of control. So what we were seeing were people on the 8th day that were allergic to this allergen, having a hypersensitivity reaction. That reaction could be either mild, moderate, or severe, like any allergic reaction, and it's dependent on your genetic predisposition to allergy rather than any comorbidity. Now, those that had mild symptoms on the 8th day, like a bee sting, they had transient irritation in their lung, and that would resolve reasonably spontaneously. And that's what we saw. Some patients recovered relatively quickly on treatment. The second subset would be those that would have moderate reactions, like a bee sting that caused a rash throughout your body. And if you left that to be settled on its own, it might take a very long while for your body to rectify that. And that was what we saw as long COVID. Long COVID, in my opinion, is just a moderate allergic reaction triggered on the 8th day that has been inappropriately treated and left unchecked for too long. And so it spirals out of control. The third subset are those that are severely allergic to this allergen and would have a severe reaction. That would spiral very quickly and would result in severe edema and inflammation in your lungs. And if unchecked, would result in a cytokine storm that would put you on a ventilator relatively quickly. So the modality of treatment followed that perspective. Every patient that came in was educated about their respective 8th day and what to look out for. So I think the education is vital early on. Every patient that came in on the 8th day was assumed to be having this kind of reaction and started on a quick, aggressive treatment. The dose of steroid in the first wave had to be titrated up. I came to an average dose of about 80 milligrams of prednisone as the minimum effective dose. Anything below that didn't seem to work. And so in the first wave, I had no deaths, I had no hospitalizations, and I hadn't found the need to get oxygen into my practice for breathless patients, because everyone seemed to, no matter how severe the presentation, recover by the next day. Quick speed to recovery. When we got into the second wave, I had now the opportunity to examine long COVID patients from the first wave, not treated with my modality. In the treatment that I did in the first wave, I had not a single patient develop long COVID. Neither did I have a patient develop any complications of COVID. So I think if you catch this early and treat appropriately, you don't get the sequelae. When I treated patients with long COVID, approaching the second wave, I took the opportunity to do certain biomarkers. To prove my theory of type 1 hypersensitivity, I needed to either show on the 8th day the release of histamine or tryptase, these are the common markers, or an elevated level of immunoglobulin E, which is the immunoglobulin that is involved in allergic reactions to allergens itself. However, tryptase was an expensive test to do. Histamine required a 24-hour urine sample to be collected. And of course, while that sample was being collected, I had to defer treatment. And if I deferred treatment, that could be dangerous to the patient because the progression could be very rapid in this illness. So I couldn't do those tests to prove the 8th day. However, with the long COVID cases, I knew that they were exposed to the allergen for long enough and to have been given sufficient time to have elevated IgE levels. And so I tested them. And every single one of them had elevated IgE levels, elevated to the point where the normal values ranged up to 100. I've had patients come to me with long COVID with values in the 5,000s. And I use that as a marker of severity and, of course, a marker for recovery. Those patients with long COVID were treated in very much the same way as a mast cell degranulation or a mast cell activation syndrome that seemed to be self-perpetuating. And so they were put onto a dose of steroid, antihistamines, montelukast, anticoagulant, and all of them, within the first 3 to 4 days, irrespective of how long they were suffering with long COVID, showed signs of good recovery. However, when you treat long COVID, because of the length of the injury, some things there will be some irreparable damage because of it. And so with long COVID cases, we do get good recoveries, but we do see some sequelae that need to be addressed. And those are simply because of injuries, because of the deferment of treatment. When we got into the second wave, we had the notorious South African variant. And so I took the opportunity to understand that. The 8th day remained exactly the same. Patients that deteriorated started that deterioration on the 8th day. The first 7 days was exactly the same. We had patients who had a sore throat for a day, recovered, spent the rest of the week perfectly fine, and on that fateful 8th day suddenly noticed new symptoms and started to deteriorate. However, in the second wave, there were a few nuances. I was seeing a lot more gastrointestinal symptoms, runny tummies, cramping, nausea, vomiting. I was also seeing that on the 8th day, it was no more breathlessness that presented as the symptom of the onset that heralded the onset of the second phase. It was more a reemergence of diarrhea. And of course, we saw fatigue. Patients would come back on the 8th day with this overwhelming sense of fatigue, where the previous day, again, they were perfectly fine. So the education changed a little to enlighten patients that fatigue is now the presenting symptom on the 8th day. And if they notice that, they must come back immediately. In the second wave, we had a lot more, it was a far more severe variant. But from examining the mutations that made the South African variant, the mutation only caused a change in the spike protein. And so I looked at the presentation. We were dealing now with a far more contagious variant, which ties in with the change of spike protein. We were dealing with gastrointestinal symptoms, which again ties in with the change of spike protein and increased affinity for ACE receptors in the gut rather than the lung. And of course, on the 8th day, I was dealing with a far more severe hypersensitivity reaction. And so that clarified that the allergen triggering this process was actually spike protein. After all, it was the only thing that changed on this variant, and it caused those three symptoms to actually change. Now, I've always had one eye on spike protein as the culprit for this trigger. Spike protein is what gives a virus its affinity for a particular host. Now, as we were initially told, we have a bat coronavirus that had jumped species to a human being, and that would be the result of a change in its spike protein. And of course, we've been exposed to coronaviruses through history, and it's the first time I've seen this kind of presentation, an allergic kind of presentation. And so usually when you are exposed to new environments, there's a risk that you will be allergic to something, seeing that it is a new exposure or an unusual exposure. And so spike protein was always at the back of my head as the culprit triggering this allergic reaction. And in the second wave, when we noticed the increase in severity of the hypersensitivity triggered on day 8, it brought to the fore that spike protein was actually the culprit. In the second wave, the treatment modality remained exactly the same. We treated the first phase of the illness as an ordinary viral illness. Patients were treated symptomatically. The aim of early treatment was to get the patient to the 8th day, having completely recovered from the first phase of the illness. So symptomatic treatment for a majority. In both waves, those that presented with signs of high viral loads, severe body aches and pains, spiking temperatures, looking acutely ill, to those patients I added plasmaquine, subset from hydroxychloroquine, just as an antiviral, and it worked well. I had those patients out of that illness within 2 or 3 days of initiating that treatment. But that was reserved for a few patients that seemed to have high viral loads. The rest were treated very symptomatically and in anticipation of what might transpire on the 8th day. So the treatment modality through the 4 waves that we are going through now has not changed. Every patient is taught about the 8th day. Every patient is meant to understand the severity of symptoms, the presentation on that day, and the importance of timeous presentation back if that occurs. After all, with an allergic reaction, quick, aggressive, timely intervention is the most vital thing. And so if a patient understands when the deterioration is bound to occur, if it does, they can present back timeously. In the third wave of the illness with the Delta wave, we saw exactly the same. With the changes in variant, we found slight changes in the initial presentation, changes in the severity of the hypersensitivity reaction triggered on the 8th day, and of course, changes in the symptoms that heralded the onset of that hypersensitivity. But the timeline remained consistent throughout, irrespective of which variant I was dealing with. Viruses tend to have a very set pattern when they infect a human body in their replication cycle, unlike bacteria. Bacteria can grow indefinitely. Viruses run through so many cycles over a period of so many days, and then they eventually are self-limited by an immune response. Like measles or chickenpox, there is an evolution to the illness from a fever to start with, through a rash that blisters, through crops, and to an eventual recovery. And that chickenpox illness has a finite time and can be plotted. So you can plot the symptoms as they evolve through the illness. And that was my aim, to plot how this virus actually infected the human body and led to the mortality and morbidity we see. So
could I ask you a question? Like,
yes.
So if you have, because the coronavirus has been around forever, I mean, like the normal, or like at least that's what we hear, like the normal or other types of the coronavirus. And have you ever noticed such a pattern before, like that on the 8th day, like, or with an influenza situation, that some people can get these allergic reactions? And is this is this the first time you see this, or is this also possible with other viruses?
It is the first time that I've noticed that trend. Mm-hmm. Other viruses, if they infect, they tend to be self-limiting. Those that have comorbidities tend to get more severe infections, and those infections progress to a pneumonia. I've never seen a patient completely recover with the other respiratory viruses and then suddenly on the 8th day take a turn for the worse, even after considering to be fully recovered. And that's what drew my attention to this being a separate pathology starting on the 8th day itself. But I've never seen that before. In fact, there's a few other things that I think were very telling. In the first wave, when I realized that I'm dealing with a hypersensitivity reaction, hypersensitivity reactions are very typical. You have to have a genetic predisposition to a hypersensitivity reaction. So it tends to run in families. Like a dad that's allergic to penicillin, his son would probably be allergic to penicillin also. And that's what I was seeing in the community. I was seeing father and sons that were severely affected, but mums that tested positive and had no second part to this. They never had a reaction. I've had mums get acutely ill and recover by the 6th day. And fathers and sons have a transient sore throat and suddenly on the 8th day presented with new symptoms and ended up critically ill. So I could clearly see the genetic predisposition there. And of course, there wasn't this correlation with comorbidity that you would expect in a pneumonia or a worsening illness. This was something new. And in the first wave, it was reported around the globe that people over the age of 55 seemed to be at much higher risk of mortality and morbidity from coronavirus illness. Now, all the mortality and morbidity of COVID illness lies in the second part of this. Nobody dies from the first 7 days of viral exposure. It's those that have a severe allergic reaction post 8th day that are the highest risk of mortality and morbidity. Those are the ones that would end up in hospital itself. So looking at that, I have started to wonder, why would it be that over 55s are more prone? And the simple explanation would be that over 55-year-old patients had been previously exposed to something very similar to this coronavirus. Now, to put that into perspective, if you're allergic to a bee sting, the first time, that's a genetic predisposition. The first time in your life that you are stung with the bee, you will not have a clinical reaction to it because you don't have the antibodies that will trigger that allergic reaction. But on that first exposure, you produce a specific subtype of immunoglobulin E for that particular allergen. The second time you're exposed to it, you now have the immunoglobulins to mount an inappropriate allergic response to it. So coming back to what we were seeing, I was under the impression that people over the age of 55 in the first wave had developed these inappropriate IgE molecules due to exposure previously to a similar kind of allergen. And that's the reason they were predisposed to having the reaction on the 8th day, not younger people. And that's what we saw throughout the first wave. But understanding that theory, it's simple to postulate that people below 55 were not reacting in the first wave simply because it was their first exposure to an allergen. However, during that first exposure, people below 55 would likely be sensitized, those that are allergic, and would have a severe reaction with subsequent exposure. So in my article that I wrote after the first wave, I postulated that the second wave will bring mortality and morbidity in a far younger population group, irrespective of the severity of the illness, just from the fact that they were more likely now to have been sensitized to the allergen in the first wave. And that's what we saw around the globe, that from the second wave, it was a far younger subset of population that were dying. But this is simply because now they were primed or sensitized to have this allergic reaction from an exposure in the first wave.
And how is that? How do you see that in connection with the vaccination? Because that's also a priming, because you have the spikes now in your blood. And do you see a difference? Because we have all these, like, what's the term in English for the Impfdurchbruch, Rainer?
Breakthrough.
Yeah, so this vaccination breakthrough.
Okay.
And that's maybe like so some of the vaccinated people also get a very strong reaction, and that's maybe because of the priming. Do you see that, or how has your observation changed, like after people got vaccinated?
In the third wave, I was exposed to vaccinated patients, so I could understand what was going on. But if you understand the underlying pathology, then you can postulate what might be the case. Now, what I'm seeing in vaccinated patients, this is with the messenger RNA vaccines, the Pfizer vaccine. I noticed that once the vaccination program had started, I was seeing patients presenting to me, a large subset, 7 to 10 days odd after vaccination with the onset of illness, presenting 7 to 10 days after vaccination with either a sore throat or the onset of breathlessness. And so there were too many of these patients presenting after vaccination, testing positive for COVID, for it to be just a coincidence. Mm-hmm. So I looked at that, and in that subset that presents soon after vaccination, there were a few patients who, on the second, third, fourth day of illness, suddenly deteriorated and their oxygen dropped. And that has never happened with the unvaccinated patients, irrespective of the variant. So I looked at that and I thought, well, I'm dealing with spike protein illness. Now, what I classify on the 8th day is spike protein illness. It's an illness triggered by spike protein, an allergic illness, but it can be other. So I classified it early on as spike protein illness, the second part of the presentation. Now, I was under the impression that these patients presenting to me very soon after vaccination were actually presenting with spike protein illness. They had missed the viral phase of the illness completely. The vaccine had caused their bodies to produce spike protein, and when it reached an appropriate concentration, it triggered a reaction. So these patients on the first day of illness were actually already into the hypersensitivity pneumonic phase of this illness. They had missed the viral phase completely and likely to be shedding spike protein or messenger RNA for the PCR test to be turning positive. So I did now with the unvaccinated patients, on the 8th day, I do a few biomarkers, your interleukin-6, your D-dimer values, your CRPs, and those give me a good indication of the second phase. They tend to be slightly elevated in the first phase of illness, but from the 8th day, take off exponentially. And so if I see those elevated markers, I am 100% sure that this patient has gone into hypersensitivity phase. And of course, I used those markers to gauge the recovery. The aim was to get them back to baseline as quickly as possible. Now, with these patients that presented after vaccination, I decided to do the very same biomarkers, but do it on the day they present with illness. And I saw the elevations, which clarified for me that they were already into the hypersensitivity phase and had missed the viral phase completely. So those patients on the third or fourth day of illness that were deteriorating and having hypoxia and the rest, they were not actually on the third or fourth day of illness. In the plot of the natural illness itself, in an unvaccinated patient, these patients were starting illness on the 8th day. So on the third or fourth day when deterioration occurred, if you looked at that from the natural course of infection, it was actually the 11th or 12th day. And it's at that point that you see people that are unvaccinated with a natural infection present to hospital. And so that made me understand that these patients that were crashing 2 or 3 days into the illness were those that were the most allergic to spike protein. And of course, the vaccine takes a little while to build spike protein in your body. So it looked like there was a 7 to 10 day odd lag between the injection and the reaction to spike protein. And that lag would allow IgE to actually develop. So in those patients that presented early on with these kind of vaccine reactions, I did IgE levels on them. And every single one of them that had a severe reaction had drastically elevated levels of IgE. So IgE in that subset of patients that presented early after vaccination became the marker as to the severity of the reaction that might occur. So those that had high elevated IgE levels needed to be watched very closely. They were the ones that could deteriorate very rapidly. And the treatment of those patients that presented a week after vaccination was exactly the same as I used from the 8th day. Steroids, antihistamines, montelukast, anticoagulant, and all of them showed signs of recovery. So when I look at the vaccines itself, we're dealing with a few different mechanisms. The immunity is different from the allergy. So the vaccines itself are meant to stimulate an immune response, which is supposed to bring you immunity against infection and transmission. However, the vaccine as well exposes you to spike protein, which is an allergen. And so the vaccine has the ability to develop a measure of tolerance to an allergen. And I think that is where the vaccine gives us the benefit of improvements in severe illness and death compared to any immune-mediated resistance to a virus itself. So I've seen breakthrough infections constantly. I've had those subset of patients who presented early after vaccination with what we suspect is COVID illness, but clearly is spike protein illness. And then I've had the subset of patients who presented a month or two after vaccination with COVID. Now, those patients are truly having breakthrough infections. We've given them sufficient time after vaccination to develop a robust immune response to the virus. And if they develop infection subsequently, then that's a breakthrough infection. And in those patients that present more than a month after vaccination, they have the typical evolution of their illness. They have the first 7 days of viral illness, and then on the 8th day show signs of worsening, typically like we'd see in unvaccinated patients. So I'm of the opinion that the vaccines itself provide us no immune benefit. Because I'm seeing patients just today alone, I must have seen about 8 patients already that are fully vaccinated that presented with COVID, with this new Omicron variant. So clearly, the vaccine does not stop infection, neither does it stop transmission. So as a vaccine, it has failed. It does not do its job. But where we see the improvements in the clinical outcome, now there's this claim that vaccines prevent severe illness or death. That is due to the vaccine being able to stimulate a measure of tolerance to an allergen, or what we would call desensitization. So when a patient is exposed to spike protein, if they are allergic, that low dose of spike protein that they're exposed to will give them a measure of tolerance, so that when they are exposed to the allergen through a viral infection, they do not develop the same severity of hypersensitivity reaction. And that is where the benefit is, in the decrease of severity of symptoms due to desensitization to an allergen, not to any immune-mediated benefit itself. And that desensitization will only persist for as long as there is exposure to the allergen. So we've seen 3 or 4 months post-vaccination that vaccinated people start to have severe illness again. That's a good indication that they're no more exposed to spike protein. So the desensitization has stopped, the tolerance has waned, and so on exposure, they will have a severe reaction again.
Sorry, we don't know each other. My name is Wolfgang Budak.
Hi, Wolf.
I have a question. Isn't it very important which way you get the contact with the allergen? So with the spikes, whether you inhale it or whether you get it injected. I think, and this is one thing, and when you get it injected, isn't there a big, because you don't aspire when you inject, is there a big chance that the acute cases that it happens when you get an intravenous accidental intravenous injection, which you have with other allergens too? You have a very sudden reaction then, and it's very often it's the heart and it's the lung. So whether it goes first, whether blood goes first after the shot is set. So what do you think about that?
I think that what we see as vaccine side effects needs to be classified accordingly. Remember that the vaccine does not have spike protein. It's a messenger RNA that gets your body to make spike protein. So the exposure to spike protein post-vaccination will be delayed in that you got to wait
How
for
long?
your body to take that.
How long?
That's the thing.
How long is it delayed?
If I'm seeing patients 7 to 10 days after vaccination triggering this reaction, then I would suspect that it takes 7 to 10 days to build the spike protein in your body.
I've seen that it goes very, very fast when the nanoparticles and the mRNA enters the cells. For instance, the endocard, the epithelial, then it's very fast. It's hours, and it started producing and showing the spikes to the blood, so that the reaction could happen within 1 day.
Yes. Look, when you talk of hypersensitivity and an immediate reaction, the immediate reaction can occur to messenger RNA. It can occur to polyethylene glycol. It can occur to graphene oxide, all the other adjuvants and additives to the vaccine itself. So hypersensitivity can occur to a wide diversity of ingredients. However, allergy to spike protein will be restricted to those patients who are allergic and would be reasonably dose dependent. Now, when you look at the myocarditis and all those kind of side effects that we are seeing with the vaccine that are very immediate effects, those might not be related to hypersensitivity, but more related to the biologic effect of spike protein itself. This has been a push from the start that I wanted research to stop focusing on the virus and start focusing on spike protein, and for us to understand its biologic effect on the body. Now, since there's a lot of information that's come out about this biologic effect of spike protein. We've seen the endothelial injuries, the affectation to the myocardium in the heart. We've seen the similarities to other pathogenic proteins like prions. And so the understanding that we should see a host of neurologic illness because of that, a host of increase in Alzheimer's and dementia. We've also seen similarities to other pathogenic proteins related to HIV. And so we expect this to have an immunosuppressive effect, subsequently causing a reemergence of latent infections or viruses, and of course, the reemergence of cancers that were in remission. We've also seen that the spike protein has the ability to enter a cell nucleus, and with its inhibition of the BRCA enzyme, can actually prevent DNA repair. And that has some grave long-term consequences in the inability of cells to repair. And of course, those that survive damage would likely form cancerous growths. We know, of course, that spike protein is a membrane protein, and so it should be expressed on the cell that produces it. That cell will be recognized as foreign to the rest of the body, and that would trigger a host of autoimmune responses dependent on the tissue that's actually making the spike protein, and depends on where it was actually biodistributed. So we know that spike protein has a wide diversity of toxic biologic effects on the body, and any one of those effects can come into play at any point in time. So from the perspective of hypersensitivity, yes, there are immediate responses to hypersensitivity, but if it's an immediate response, it's very likely to be an immediate response to one of the adjuvants or the messenger RNA. Because I've seen 7 to 10 days, like I've said, after vaccination, that I'm seeing this allergic propensity show up. So I'm of the opinion that it takes 7 to 10 days for a sufficient amount of spike protein to be built to trigger this allergic process. If I had to put into a little bit of context how I see this pandemic, if you looked at another chemical like penicillin. Now, penicillin's biologic activity on the body is that it's an antibiotic. To get that biologic effect from penicillin, you need to have a full course, a certain length of exposure to have that biologic effect. Now, if I, like the virus does, gave everyone on the planet a single dose of penicillin and then isolated all of them for 14 days, I would not see the biologic effect of penicillin, so it would not act as an antibiotic because it was a single dose. However, all those that are allergic to penicillin due to non-treatment would die. And I think that's what's happened with the virus. People that were allergic were isolated, not without understanding the illness, and because of the delay of early treatment and intervention, had demised. Now, when you take a vaccine, you are exposed to spike protein for a longer length of time and maybe at higher dose. And so you would see its biologic effects like a full course of penicillin. And so the need to understand the biologic effect of spike protein on the human body. And so I'm happy that research has taken us down this road to understand what the potential of spike protein is. And if we look at the VERS system, and of course long COVID, those would be the two reportings where patients were exposed to prolonged spike protein. We might not see the numbers, the absolute values, because of the underreporting and non-reporting of symptoms and deaths. But we can look at the spread of pathology that we see. And if you look at all the reports on the VERS system, the prediction of what spike protein might do as a biologically active substance is exactly the spread of pathology that we see in the VERS system. We see the endothelial injuries resulting in strokes and heart attacks and blood clots and emboli. We see the myocarditis, we see the neuropathies, we see the increases in Alzheimer's and dementia. We've seen the immunosuppression, the emergence of latent viruses, the reemergence of cancers, the spiraling of autoimmune conditions, Guillain-Barré. We've seen CJD showing up. So some very unusual conditions have now become the norm. And so it shows that spike protein's biologic effect is the likely culprit here. Whether it's reported, whether the figures are accurate is irrelevant. The spread of pathology is what I'm more interested in. And that spread of pathology is dictated by the biologic activity of spike protein, and that pans out. So I think that with the vaccines itself, we got to be very cautious about our reporting of side effects. All-cause mortality is vitally important to look at, and of course, excess deaths. If we don't know what's in the vaccine, then every single side effect is considered to be a vaccine side effect until we prove otherwise, not the other way around. So no cherry-picking side effects. We'll never figure that out.
And can I ask you, when you see people who are one time vaccinated, 2 times vaccinated, and maybe even with a booster shot, so the people who got this allergic reaction should expect to have a maybe even stronger or another, or do you see that's happen again and then again? And so what would be the perspective for these people?
That is something that I found very strange. In general, people that have had a severe reaction with COVID itself tend to have a severe reaction with the vaccine. The first dose of vaccine is a mild reaction, and the second dose a far more severe reaction. However, I've had patients that have had severe reactions with natural infection who had no reaction to the vaccine. And I find that very confounding and confusing. But of course, we are also aware that there is inconsistency in the vaccine itself. The doses or the vials are not the same. Some were found to have just normal saline in them. And so I think that is likely to be due to the inconsistencies in the vaccine rather than any inconsistencies in the illness itself or the response to the illness.
Mm-hmm. So very important, yes.
I think as well that the first dose is a mild dose, and you're not sure what patients are actually getting in their first dose. The second dose, in all patients, the second dose seemed to be far more severe reactions. I've had many patients demise with the vaccines. I've seen a lot of neuropathies, a lot of strokes, a lot of cardiac issues. Unfortunately, the medical fraternity refuses to accept that. I've had patients being told that it's not the vaccine, even though the side effects occurred a day or two after the vaccine. So I think that the information that we collect from this is never going to be good information, good data, because we're not looking at every case and we're not looking to understand every case. I think we're just trying to justify the vaccine by brushing a lot under the carpet itself.
I have another question. I've heard that the spike of hepatitis B is similar a little bit to the spikes of coronavirus. And have you heard about that? There are similar proteins. Half of the spike is said to be similar. Could it be that those people, having been vaccinated against hepatitis B, react differently than those who are not?
I think with the spike protein and its ability to suppress immunity is where the problem lies. There are a lot of latent viruses in our body that are suppressed by a good immune response, and that immune response tends to be lifelong. However, if you suppress that immune response, these latent viruses are going to show up. India at the moment is having an outbreak of dengue. That is very strange, strangely after a mass vaccination campaign. So we are seeing a lot of latent viruses coming to the fore. I am actually looking to see my HIV patients, and I'm watching closely their CD4 counts and viral loads to see whether those that are vaccinated have any worsening. A majority of my HIV patients are very well controlled. And so any change in that control will be obvious. However, a lot of the patients that I have that are HIV positive are very skeptical about the vaccines, and I think a majority of them have refused to take it. So in the few that have taken it, I'm waiting with bated breath to see what the outcome might be.
Wow.
What about the Omicron variant? We have heard many stories from people, both Germans and other people who have been living in South Africa for a long time. And one of them, I think we're going to show a short video at the end of our session. One of them traveled from one hospital to another in order to find out if the hospitals are really overwhelmed with victims of this new Omicron variant, in particular, if there's so many children. And each and every one of these hospitals was almost completely empty.
Yes.
How can that be?
Rainer, I think this is fear-mongering. I've been seeing a lot of the Omicron variant. I've seen hundreds of children through this pandemic. I've not had a single child progress into the second phase of illness. And seeing that the second phase is where all the mortality and morbidity reside, it's clearly understandable that children are not at risk of mortality and morbidity. Their immune systems are not mature enough for them to develop this kind of hypersensitivity response. It is almost a protective mechanism. So children being exposed to new environments at the start of their life are given a bit of latitude to tolerate them. So the immune systems are learning. So you don't have this overreaction. But once a child reaches maturity, I wouldn't say a specific age, but once a child reaches maturity, the immune system changes, and then they're at risk of having hypersensitivity reactions. Now, understanding that children are not at risk, so I don't see the need to be vaccinating children. Children have a robust innate immune system, and they have the ability to learn. And I don't think that children were ever super spreaders or ever put anyone else at risk. So the campaign to vaccinate children needs an irrational push to fearmonger parents into thinking that their children are at risk so that it would justify the vaccination. Now, with what I'm seeing with Omicron, there are a few changes that have occurred. Patients are not having the typical upper respiratory symptoms that we've seen with the other variants. They are presenting more with fatigue and with headaches, some of them with gastrointestinal symptoms again. But from all that I've seen and all that I've endeavored to look into with Omicron, it is a mild variant. There is no hospitalizations, there is no critical illness that seems to be associated with it. And even those patients that turn on the 8th day, it is a very mild turn that can be easily suppressed with the right appropriate medication. So this is a very mild variant. This is what we would expect from a pandemic, like we did with the Spanish flu. Viruses have no will to kill their host. A dead host is of no consequence to a virus. So as the pandemic evolves, there's an expectation that viruses, the variants, will become more contagious, but will become less pathogenic, cause far less illness. And that is the trend in general infections. And so when Omicron surfaced, it was expected. I would have expected that the first and second wave would have been the most severe, seeing that patients needed to be desensitized or sensitized to respond. The third wave would be the building of tolerance, And the fourth wave would drive this virus into endemicity. So it will become an endemic pathogen that we'd all learn to live with and be well primed to do that with our natural immune response. And so that is what Omicron actually is. I would be cautious because we know the virus is man-made. And so if Omicron was another one of the variants that they made, there might be a sting in the tail. So cautiously optimistic.
I have another question. There are fruits we never ate in Europe many centuries ago, but now we import them, like kiwi fruit or such fruits. And there was lots of allergy against those fruits. How many generations does it take until it's a fruit you are used to and no more diseases appear? What do you think? How long does it take to adapt?
Look, I think that's a genetic predisposition, and I think it's dependent on the type of allergen and how severely it triggers a reaction. If you look at penicillin, you would have expected that people that were allergic to penicillin would have become tolerant by now, but I think it is dependent on the exposure. So if your dad was allergic to kiwi fruit, but he kept eating it in spite of that, then there's a higher propensity for you to become tolerant to it because it would become part of his genetic makeup and he'll pass that on to you. But if he's allergic to kiwi fruits and stayed far away from it, you'd probably still be allergic to it. Okay. So I think the process of learning is important.
Well, we cannot avoid the contact with coronaviruses. We cannot avoid the contact with viruses. With kiwi, we can, yes.
Yeah. Look, with Omicron, when it came out, the whole world jumped up and decided to ban South Africa from travel abroad. And I thought that was the most nonsensical thing anyone could do. At the start of the pandemic, I was asked, what would be the best way to make a vaccine? Because I thought that messenger RNA was the stupidest technology to use to make this vaccine. Just to put context to that, we're taking messenger RNA, putting it into a cell. That cell has to make spike protein, which is coded for by that messenger RNA. That spike protein must be recognized as foreign and trigger an immune response. That immune response is meant to build specific antibodies to that spike protein. And if those antibodies are neutralizing, and if you are exposed to a variant that has the same type of spike protein, then those neutralizing antibodies will kill the virus. And that is the way in which the messenger RNA is meant to work. So I asked a question. Messenger RNA needs to be stored at minus 90 degrees Celsius. We're not sure of its biodistribution in the body. We're not sure how long-lived it's going to be. We're not sure how much of spike protein it will make. We're not sure how long it will make spike protein. So we have all these variables that make the vaccine difficult to monitor. But the end product is a neutralizing antibody to spike protein. So why didn't we inject people with spike protein directly? We would have got to the same end point. The spike protein would have triggered an immediate response, and that would have caused the development of antibodies to spike protein, which would have given us the same end point without the messenger RNA involved. Nobody can seem to answer that. A spike protein would be easier to manufacture. It wouldn't require a specific minus 90 degree Pfizer fridge. We could dose it absolutely perfectly dependent on patient's body weight. We would know its half-life and exactly how long it will be eliminated from your body. So it's something we could control far more effectively. So what was the need to use messenger RNA to make spike protein? Then coming back to the vaccine. The best vaccine would be a live attenuated vaccine. So I said, look, take the mildest variant of coronavirus and use it as a candidate to make a live attenuated vaccine. That vaccine would cause mild illness, and you would develop natural immunity once you recover. And seeing that it caused mild illness, it would be self-spreading. So you won't be required to vaccinate the entire population. whoever you vaccinate, just advise that when they develop symptoms, they must go and play in a crowd, and they'll spread that vaccine to every person around them. So we'd create an artificial mild pandemic that would spread very quickly, and we'd develop natural immunity and without the mortality and morbidity. Now, with Omicron, God seems to have given us that. We have a mild variant that's highly contagious without the mortality and morbidity. And I can tell you Omicron's better than the vaccine in many ways. So it should be the replacement for mass vaccination. We should all get Omicron and get natural immunity. And the natural immunity would be far better than any vaccine-conferred immunity. So closing our borders is the most nonsensical thing to do. Closing your border and trying to vaccinate the population out of Delta is stupid. Open your borders, let Omicron come in, and it'll displace Delta without a second thought. And you'd have a pandemic of Omicron that's mild, without any consequence, and we'd all get to herd immunity without lifting a finger. And I think, people need to, the science needs to do this.
We will have the immunity in the right place. We won't have it inside somewhere,
Exactly.
but we will have it in the right place.
Exactly.
And can I ask you, like, these
Omicron's fear-mongering, nothing more.
So if you say that for the what's your explanation that for the Pfizer vaccine, there's all of a sudden the minus 90 degrees Celsius is not necessary anymore, but it can be stored in a fridge, I think, with like normal...
If it's spike protein.
How is
if
that?
it's just spike protein. Why need the mRNA? Manufacture spike protein. Use it as the trigger.
Very good question. Very good question. Maybe the mRNA is just a distraction from the real danger, which seems to be a highly toxic.
But if you have a vector, you don't need such a low temperature, I think.
Yes.
You can have less you can have more normal temperatures. So this is the difference between those two.
And as well, when I look at COVID illness itself, COVID illness is not caused by coronavirus. Coronavirus causes pathology, the viral illness, but that's self-limiting and transient, and of course leads to no consequence in a lot of people. So the primary pathogen of COVID illness is actually spike protein. Spike protein is what leads to all the mortality and morbidity in COVID illness. So coronavirus is just a vector. It's a vector that brings spike protein into your body and exposes you to that allergen. Just like the virus is, the vaccine is a vector for spike protein. So we're dealing with two vectors. You're gonna, it's a joke amongst my patients here in South Africa from the start of the pandemic. We're dealing with an airborne virus. We're dealing with a faulty PCR test that would never allow me the latitude to isolate it effectively and in so curb its spread. It's like trying to find the pea in a swimming pool. You don't have something to differentiate the water from the pea. And so it's a laugh with my patients. I told them from the start that the likelihood is that you are going to get coronavirus at some point during this pandemic. So choose your variant carefully.
Shankara, I'm really impressed. This is the first time that I understand a medical lecture, and I've listened to quite a few because I've done a lot of medical law.
It's what will keep you safe, Rainer.
Yeah, this is great. And it's important to understand these things. It's also important to expose these things, to make people understand what the real dangers are. It doesn't seem to be, it's the spike protein, obviously. It's the spike protein. And everything else is just, well, we don't know it yet, but it does look as though everything else is a distraction or an experiment.
I have a question. What do you think of the fusion without induced by the spike protein?
Sorry, I didn't get that question, Wolf.
Have you heard about it?
I didn't hear your question.
The fusion without, so the spike protein makes a cell fusion, is inducing a fusion of cells, so that several cells go together and have multikaryote cells afterwards. we were discussing that with Mike Eden. It was question because of fertility. There is syncytin-like mechanism, and which could be antibodies against syncytin, and we were afraid that there were no experiments to exclude infertility after this vaccine. And this is the question of fertility being influenced by getting vaccinated, which takes a lot of time to notice.
Yes, especially when you're going to vaccinate children. Yes. It might take a long while to realize that it's affected their fertility. Look, with spike protein, I had a discussion last night, and I was taken to task for calling it a toxin. I was taken to task for calling it a poison. But if I had to understand what I see, the facts are the facts. And I've got to take these facts and try and understand and make logical sense of what's transpiring around me. Now, from what I see, I've got to draw a picture as to what's going on around me. Now, I asked a simple question. I said, if you got up one morning and found someone in your home, and mainstream media told you that he's there to visit you and keep you company, and so you believe that. And when friends come by, you tell them, no, this guy's here to keep me company, and he's here just to visit. But that doesn't explain your missing television and the car missing from the garage and the front window broken in your house. And so as much as you wish to accept that and tell everyone that he's there for a visit, you might start to justify the missing TV because you start to realize he's probably a burglar, but it makes you look like a fool to admit that. But once you do admit that he's probably a burglar, then all the facts start to make sense. And so that's what I have to do with the facts that are in front of me. So when I look at spike protein, I know that it's an engineered protein of the receptor on a virus to cause it to move from a bat to a human being. So I'd expect that that was a feat of engineering to get the receptor changed. But when you look at the complete protein structure and you start to realize the pathogenicity of this protein, I don't think nature will conspire to find all the bits of protein around us that would probably kill human beings and then in one mutation put it all together on the spike of a new virus that miraculously jumped from a bat to a human being and became the most infective human virus we've seen in a long time. So I'm of the opinion that spike protein is likely to be the most well-engineered human poison ever made. And that's what it looks like. Now, a can of insecticide on my desk is toxic, but it's a can of insecticide. The day I decide to force my family to drink it, it becomes a poisoning. And so when I look at what's going on around the world, the mandating of vaccines, that whole game, I think that this is a global mass poisoning. And until I have any other evidence that points or paints a different picture, that's what I suspect we are dealing with. Because the vaccines have absolutely no scientific basis, yet they're being punted as a health intervention.
I just used the chance you are here, and what do you think about this technology of Novavax with all those spikes on some nanocylinders, and they are doing it RSV, the respiratory syncytial virus, they have the spikes, and they have the spikes of the coronavirus, and they put it in some nanoparticle, and they want to inject this. This is the new technology. Many people hope that they don't want mRNA. They are looking forward for this. What do you think about that?
Wolfgang, whether it's mRNA technology, whether it's nanotechnology, it is absolutely wholly unnecessary. We are spending our time chasing bees and killing bees, and we're not treating the people who are allergic to the sting. It's a complete waste of our time. If we concentrated solely on the mortality and morbidity, like we should have done from the start with early treatment to build understanding about this pathology that we see, it would make vaccines unnecessary. Now, I wrote an article about this, describing from the Spanish flu all the way to what we're going to see and how we would get to tolerance. And it became one of the most controversial articles written at the time, simply because there was a line in it that stated that if we could curb all the mortality and morbidity of COVID illness with early treatment, it would completely negate the need to rush a half-cooked vaccine to market on a global scale. And of course, I think they thought that was a dig at vaccination before vaccinations were even a thought or on the agenda. So it became controversial just for one line. So I think vaccines are completely in the wrong direction when you talk of COVID illness. I'm not an anti-vaxxer. I have all my vaccinations. This is inappropriate science. And I cannot justify anything that would injure my patient. It's the first principle is do no harm. So as long as I see a vaccine ability to cause injury, I've got to weigh that risk up against the benefits it might provide to that patient. And quite frankly, with early treatment, no one is really at risk. If you do not treat, then everyone's at risk. So yeah, when you look at the comorbidities as well, a bee doesn't actually care whether you're fat or thin or whether you got diabetes or high blood pressure to kill you. All it cares is that you're allergic to its sting. So yes, the comorbidities do play a part, but they play a part in the recovery from the illness, not in the pathology of the illness itself. So if you are diabetic and you have a bee sting, you have more risk of severe illness. But the bee sting is not going to kill you because you are diabetic. It will kill you because you are allergic to a bee sting. So I think a lot of this needs to be brought in. If you look at the vaccines itself, the vaccine should stop infection and transmission. And that's what gives a vaccine a group benefit. So if you take the vaccine and it stops infection and transmission, you actually protect me. And that's the population benefit of the vaccine. So it either stops infection or transmission. We don't talk about decrease. Infection and transmission are variables that have many factors that play a part. So a vaccine either stops it or it doesn't. If they have this claim that it decreases transmission, that's dubious. If a person is highly infectious and across the road from me, it doesn't affect me at all. If a person is mildly infectious and in the middle of a crowded dance floor, it probably infect everyone around it. So it's either it stops infection and transmission or it doesn't. Now, clearly Pfizer and the rest have acknowledged that this does not stop infection or transmission. So quite frankly, that means you haven't proven a group benefit to your vaccination. Now, saying that it prevents severe illness and death is a therapeutic benefit. My treatment prevents severe illness and death, but I don't expose the entire planet to the side effects of my treatment. It's limited to those that are unwell. I don't go around giving people paracetamol in anticipation of a headache tomorrow. And when that wears off, give them another in case the headache hasn't shown up just yet. They would experience side effects from that. And that's where we're going with these vaccinations. Repeated doses to try and prevent you getting a severe reaction to spike protein. So you haven't yet proven a group benefit. The prevention of severe illness and death is also an individual benefit. So if you take the vaccine, you might not be severely ill or die when you get COVID illness. But that benefit is not transferable to me. It has no bearing on me whatsoever. So if I treat you for the flu, I can't expect your neighbor to improve with your treatment. And I can't understand without this population-based benefit, the justification for mandating it globally. Unless you've proven a population benefit, there is absolutely no logic to mandating something for a group. You haven't shown a group benefit.
Yeah.
Makes perfect sense to me. It all ties in with what everyone else has told us, except this is the most comprehensive lecture I've ever heard on this. And it makes perfect medical sense, even to a layperson like myself. Excellent.
Rainer, my push from the start, when I wrote this article, I got a lot of flack, and I knew that I'm dealing with governance structures that are suppressing information, that are coercing people. I knew from the start that I'm going to be dealing with this problem. So my push has always been to educate doctors and to educate people. If the doctors know what to do and the people know what to look for, I don't need anyone's permission to save lives. And so I knew from the start that patient education is vitally important. It is how they've coerced the population through the fear and the rest. So getting people to understand what's going on is vitally important. The layman on the street is who's important. You know, I put the vaccinations into, I gave an analogy that made a huge impact on people around me. I said, look, the vaccine provides you with an individual benefit. So if you looked at the vaccine, it's akin to skydiving. An individual risk, an individual benefit, and an individual choice. So when I skydive, if I have to die, there's no collateral damage to people around me. So I have the choice to skydive. Now, the vaccine is someone telling me that I should skydive to protect the person next to me. And I ask about the science. How does me skydiving protect this guy next to me? And you say, well, follow the science, but you can't show me the science because you've got no group benefit. After a few months and you're getting annoyed with me, you say, okay, if you don't want to jump, I'll give you a beer and donut. Why don't you? And I don't need your beer and donut. I just want to know how it protects the guy next to me. After all, I like him, and if it protects him, I'll probably take the plunge. But give me the information that shows me that I'm going to protect him by taking this risky act. And you haven't. Now humanity is at the point where you're threatening to push me out the plane. And you still haven't shown me how it protects this guy next to me. And of course, I've become very suspicious of your motives because you offered me a beer and donut. Now, when I look at the parachute you've provided me, it's leaking. It's got too many holes in it. It doesn't look very safe. And when I look at the spot on the ground where I'm supposed to land, there looks like a few dead bodies down there. And when I ask you about it, no, nothing's wrong. Don't look there, just jump. Now, if I stuck you on the edge of an aeroplane with a leaky parachute and a few dead bodies on the landing spot, I'm sure you'd be hesitant too. So I think vaccine hesitancy is warranted. You've got to be an idiot to do this. So when I look at it, sometimes I think, you know, it's just a play on words. It's just fear mongering. And I've looked into the entire psychology of what's happened around me. And yes, it is mass formation. It is an opportunity that they are taking to reset society. There's economic agendas, there's social agendas, and people are so hypnotized that they don't actually see it. They were convinced about a foe that you couldn't see. We were told the safest place for us would be in jail. So we gave up our freedoms and our businesses were closed and we went and sat in jail, hoping to be a little safer. From an airborne virus, I can't understand how that works. But we're at a point now where we want our freedoms back. And to get those freedoms back, we have to take a vaccine. So we weren't put into jail for our safety. We were put into jail to curtail our freedoms. And so we were herded like cattle into a pen. And the only way out is through a dip. So vaccination or you stay in jail. So I think the society doesn't realize that this has more to do with the curtailment of their individual freedoms than any healthcare intervention. And unfortunately, it's brought out a lot of pre-existing prejudices in people. So suddenly now you take a vaccine and you think it gives you blue blood. You're allowed to sit at the front of the bus and I'm relegated to the back. But I guess in 6 months' time and your vaccine's expired, you're going to have to come sit at the back of the bus with me with your side effects in tow. So I think people are just being coerced and they don't realize that this is something that has grave consequences for their freedoms in future. If we bring out the digital passport system, look, the passport is illogical in any way. We're giving a vaccine passport to people where we haven't actually clarified that they've had an immune response to the vaccine. So we should be giving out immune passports. Every patient, whether they have immunity that was come to through a natural infection or vaccine induced, deserves a passport to be free in society. You are immune to the illness. Now, we don't want to acknowledge natural immunity, and we're handing out a passport without testing for immunity conferred by a vaccine. Now, I think the reason for that is if we developed a test to show who's immune, we'd probably find that the vaccines have failed and very few people that are vaccinated are actually immune. So it's a shot in the foot.
I think they do something else now. They're analyzing our genome worldwide, and they find out who will be allergic. And so they can focus. And the next time they fearmonger, they will very, very intelligently focus on certain groups of people whom they know who are to be targeted and where they can reach something.
Wolf, coming back to that, I did a submission to the King of Malaysia about the side effects of the vaccine. I was hoping that on religious grounds, he would declare fatwa and I would be able to influence the Arabic world from taking this vaccine. And part of that was to look at the trend around the world. And if you remember, in the first wave in America, it was mostly the Black population of America, the African American, that was affected. They thought that it was because of lower socioeconomic group, lack of access to medical care and all that kind of thing. But here in South Africa, I saw exactly the same thing. The first wave was majority, if not all, Black patients. I had not a single Indian or white patient in the first wave. And of course, I looked at that and thought, well, maybe it's because the Black clientele, being of a lower socioeconomic group, didn't have the ability to institute lockdowns and isolate, and so it ravaged the Black community. In the second wave, I noticed that it was mostly Indian patients, and Indian patients of Indian origin, not the Muslim community. And that that was the second wave. When we got into the third wave, it seemed to be primarily the Muslim community and the white community that was affected. So it seemed like the different variants had an ethnic propensity.
Do you
That's
remember?
A bad omen.
Do you remember the WHO recommending very, very high dose of hydroxychloroquine, a toxic dose of hydroxychloroquine, and you know that there is the favism is very, very spread among Black people. So if Black people got hydroxychloroquine, almost up to 1/3 of them would react because of favism with dyspnea and all this. It may be they stopped it after the first wave. It was published then that it is dangerous, so they stopped the high dose hydroxychloroquine. This may be one reason why in the first wave there were many Black people dying and many people Black people who were hurt. I just want to mention this.
Yes, I think that the powers that be, we are dealing with a well-engineered virus and a mandated vaccine. So again, looking at this stranger I found in my home, I would say that the person that made the virus is the same person that made the vaccine. And they understand full well what the effects are going to be. Remember that when you engineer a virus, you don't have to only engineer its effect. You can also engineer in a pattern of mutation. And so after every so many cycles, the virus would change or mutate according to predetermined parameters. So the mutations affecting different subsets of community might have been pre-planned. This might be a kind of ethnic cleansing in that different variants have a propensity for different populations. Here in South Africa, I saw the Indian population affected in the second wave. And if you remember, the second wave in India was the most deadly. So it looked like that variant had a propensity for that ethnicity. So I think there's a lot more going on than meets the eye. But I think if we understand we're dealing with the burglar, we'll figure it out a lot sooner.
But can I ask you, like, do you think if it was like a natural, mutation, is it kind of realistic that this natural mutation would have these ethnic, preferences? Or would we rather need to think that there was like a new virus then, for instance, like put out, if we follow that train of thought, like in South Africa, for instance, targeting the Indian community, or like if it comes from India and then moves over. But do you see what I mean? Like, is this like,
yes.
Is it realistic to think at all that it can be by a natural selection, this virus also all of a sudden becomes more toxic to white people or to black people or to the Aborigines?
When you look at the original virus, we know that it was made in a lab. It has no ancestry. So you can't trace back the mutations that occurred to bring it to that point. Yet we got inventory of coronaviruses through the ages, and we can see how they've changed and mutated and evolved. And suddenly you have this virus that doesn't have an ancestor. So it's definitely made in a lab. Then when you look at mutations tend to be very definite in time, a process. So we know that it takes so many years for a mutation to occur in certain species. And we use that when we analyze genetics to work back in time to see when divergence of species actually occurred. Now, so we understand mutations, but we're dealing with a virus where in one fell swoop with Omicron, we had 30 mutations in spike protein and nothing leading up to it. So usually when you look at mutations, they occur one at a time. You get one mutation, that becomes a dominant strain if that mutation gave it a selection advantage, and then you get another mutation. And so you can look at these mutations evolving over time. Now, to suddenly have a variant that has so many mutations in one spot that gave it a selective advantage, and of course, no mutations elsewhere, is very unusual. If you had a high rate of mutation, the high rate of mutation would influence the entire virus. And that high rate of mutation would lead to a lot of variants that are actually, they actually don't have the ability to infect. But that's not what we're seeing. We're seeing variants that have changed drastically and have an even better ability to actually be contagious. And that I find a little strange, that we have this level of mutation with this virus. It can be that the new variants are simply put out there and they spread. They are, again, lab made. And that's the reason I say with Omicron, we need to be very cautious. Omicron might have been, yes, with any virus, man-made or not, there will be a process of natural selection. So let's pray that Omicron is a natural selective process of a man-made virus that has taken away its pathogenicity and will give us long, robust natural immunity. However, we got to entertain the thought that Omicron might be another man-made variant. And if that is so, then I guess we got to try and understand what the long-term effect of that is going to be. So with a milder variant, we might drop our guard and allow it to spread worldwide. But we might, in a few months' time, realize the gravity of an Omicron infection. My concern is that there's been some mutation in the furin cleavage site of this new variant, and that might give it the propensity to spread into different tissues and, more importantly, breach the blood-brain barrier. And if that occurs, I would expect to see neurologic effects. But those neurologic effects might be deferred. They might only become clinically apparent a few months down the line. And so we got to be very cautious about this being a mild variant or classifying it as a mild variant. We got to understand the entire ambit of what this new type of spike protein can actually do. And so I think the caution is always warranted. I examined the patients with Omicron very closely, understanding that perspective. And the patients that, look, everyone talks about headaches and fatigue, but I've noticed that the headaches that present are atypical. Patients complain of this vibrating sensation in their head with the headache. I've also started to see patients complain of strange visual symptoms, the sensation of a fan blowing on your eyes, if that's how best I can describe it for now. But these are the kind of symptoms we need to interrogate a lot more closely to get an understanding of what truly is going on. And it's only time that will tell us that we've completely recovered from Omicron and it has no long-term or delayed effects. So I think we need to be cautious. We are dealing with an engineered pathogen here. And we need to keep our eyes open.
And I have one more question. Like when we're looking at genetic differences between people and if they can be classified, you know, like say, like even like also within Germany, there might be certain types, like if you're looking at one village, you know, it's all white people, for instance, look at one village and maybe they have a different genome, like, I don't know from what could be the variations, but you know, that it's possible to then target is exactly that, you know, doesn't need to be like a big variance, like in like say people from Africa and people, white people or so, but it can be like small, maybe you could target even like little tiny things that could be like hits like 2,000 families in Germany or something.
Yeah.
So
you're looking at better ways to risk stratify, to see who's at high risk before they actually get the illness. Now, to do that, I mentioned this in the article that I wrote. If this is hypersensitivity has been conclusively proven. Marcus Sanchez and Kenneth Day wrote an article in August or September last year that postulated that this is hypersensitivity, immune-mediated pneumonitis rather than a COVID pneumonia. And I contacted Marcus and I told him that that was exactly the article that I wrote, but I had proved it on a clinical basis. And so we've been collaborating ever since. We're looking to publish a comprehensive article bringing the science and the clinical and observation therapeutic trial together. Subsequently, I think in August this year, I think it was in China, that a research paper was published where they looked at the exact immunoglobulin E subset for spike protein. And they found a correlation between those levels and the severity of illness. So clearly, that's how it works. The higher the level of IgE, the more allergic you're likely to be. Now, IgE testing is done commonly for other allergies, milk and gluten and the rest. So my aim was to push to have the development of a specific subtype of IgE, spike protein specific subtype. And if you identified that subtype, then you could do a quantitative test on every patient to see who, first of all, has this subtype and the levels. And so those that have the subtype are prone to having a reaction on the 8th day, and those with high levels of the subtype are prone to having a severe reaction. That would be one of the most important risk stratification tools we could ever have, more than whether you're fat or thin or diabetic or hypertensive. That would tell us exactly who's going to react on the 8th day. And of course, everyone's been distracted by the virus. And so it's been a bit of a push to get science to look in that direction. This is something I wanted to do in June last year when I realized hypersensitivity. But I've contacted quite a few universities for assistance, but I've got no feedback from any. After all, their funding or their funders would push them to investigate vaccine efficacy rather than anything that would solve the problem.
Is there any chance to have a scratch test?
That's what we were going to do. We were going to, you see, they got mRNA vaccines. If they had spike protein vaccines, that would be a simple thing. But it would be simple to scratch a patient on the skin and put some spike protein on it and see if it flares, like a Manto test that we do for TB. Yeah. It's simple to gauge allergy. So I don't think we need to go through the genetics of things. We need to just understand who's going to react. And to do that, every time the spike protein changes, we just got to make sure that we test who's allergic to the new type of spike protein. But what I've seen so far is that it seems to be the same kind of subset. So I think it is, it's almost like a mixed bag of nuts. If you're allergic to nuts, then some are allergic to walnuts and some more allergic to peanuts, but you're allergic to nuts. The different types of nuts might trigger different severities of allergy, but you're allergic to nuts. Now, just in that perspective, the mixing of vaccines is a dangerous thing because you might be allergic to peanuts and not allergic to walnuts, but a bag of mixed nuts poses a unique risk to you. So would a mixture of vaccines pose a unique risk to you as well. So yeah, I think we need to be cautious about mixing the vaccines.
So if we're lucky, Shankara, then the Omicron variant will lead us out of this catastrophe without them, the other side, even wanting this to happen. But if we're lucky, this is as you described it, let me read it. It's a natural selection process of a man-made virus so that it more or less eliminates itself, right?
Yes.
But we have to stay careful.
Rainer eliminates the illness.
This is very, very,
of course.
yes, yes. It's very much contradicting what Mr. van der Busche always is telling, Van der Busche. And I think he's just sent from Bill and Melinda Gates Foundation to the fear-monger again, I think.
No, look, I think we got to understand that we're dealing with two types of people here, vaccinated and unvaccinated, even though I hate to distinguish. But the unvaccinated, when they get this infection, they will develop a wide, robust response to the Omicron variant, which would hold them in good stead in the future. However, those patients that are vaccinated, whether infected before or not, we know that the vaccine damages your immunity. And so the question that needs to be asked is, do vaccinated patients, when they are exposed to a natural infection, have the ability to develop a robust, broad, natural response? And if not, are they going to be the subset of population that are going to be prone to reinfections? Because developing a vaccine that gives you a non-neutralizing antibody response is almost a distraction to a good immune response. So when you are in contact with the virus, your immunity looks out and sees that you have soldiers fighting this, even though it does not recognize that the soldiers are ineffective. And because it thinks you're fighting the virus, it won't mount a full, robust response. And so vaccinated people may be compromised in our aim to get to herd immunity. And I think that's a big issue.
Yes, it is.
And that's the reason the pandemic of the vaccinated, besides the side effects and things we see, they might be the subset of population that leads to the perpetuation of this virus. In any event, coronavirus will become endemic. It will become endemic, and we'll never eliminate it from our environment. It has other animal hosts, dogs and cats and other vertebrates. And so we'll never eliminate it. We're not going to go vaccinating every animal on the planet to try and eliminate this. It doesn't need to be eliminated. It will become endemic. The problem is that with the vaccinated forcing selection away from the vaccine, we might see more severe illness. There won't be the general trend towards milder illness. You can have a vaccinated patient incubate the virus and have a more severe variant suddenly become more contagious, because it's not the natural selective pressure that you put on a virus.
You know that there are two variants of vaccines now in the clinical studies that are self-spreading.
Yes.
They produce two vaccines that they are said to be self-spreading because the virus is amplifying, is replicating, and so you can just infect your neighbor with a vaccine. And what do you think about that?
Again, Wolfgang, now we're building beehives. It's crazy. When I look at it, I think, do we actually need to go through all this? Don't we have better things to do with our time than to be chasing these bees around when they're not really?
These are fantastic times for people who are thinking 10 years have ideas about vaccines and about interfering with our immune system. They all want to have patents. They all want to earn money. And now this is the time they can try it out, and nobody says no because we are threatened so much and we need to find something to fight it.
You see, this is the issue as well. The fact that I understood that on the 8th day we're having hypersensitivity, and the fact that the rest of the world was chasing a virus, that tells me that very few people on the planet actually understand the immune response to a natural COVID or coronavirus infection. And that is where we failed in trying to treat this. Now, if we do not understand the body's natural response to the virus, what right do we have to influence the immune response of a planet through a vaccination program? We are running blind with that. It makes no sense at all.
I compare it with the language. When you invent a new language and you spread it, and some understand it, some don't. It's like Babylon a little bit. It crashes. Nobody will understand anybody anymore because it's all mixed up, and all the reactions established for centuries or for thousands of years, and the communication established is just confused by all this, which is suddenly happening.
I think a lot of it has been science going in the wrong direction over the past 50 years. And I think that direction has been too greatly influenced by finance. Scientific discovery is stifled by big pharma itself.
Just forbid the patents and everything is solved.
Yes, you see, when you look at scientific discovery, if you're testing a drug, which you know nothing about, against a population that is diverse, then you will get, in examining the effect, you'll get a bell-shaped curve. A majority will have what we'll see in the center, the effect of the drug. You'll have a tail on one end with side effects and a tail on the other with no effect. But our focus is always on the center of the bell, because we're trying to understand what this drug does. And that is what randomized clinical trials are meant to do, show us the consistency. But that doesn't give us any new information. It just clarifies what we want to understand. Now, when we look at coronavirus, here we're dealing with the effect of a virus against a population. But it's not that we have no knowledge of a virus. There is a huge amount of knowledge surrounding what a virus does. This is not the first respiratory virus in history. So again, when you look at how this virus influences this variable population, you will get a bell-shaped curve. A majority have the symptoms that are grouped in the center, and you'll have a tail on either end with the unusual kind of symptoms. Now, where scientific breakthrough lies is not in the examination of the center of this bell, but in the understanding of the tails. So the greatest scientific discoveries throughout history were made by doctors coming together either in the doctor's lounge or the pub at the end of the day, discussing their unusual cases and trying to make sense of it. And that is where new discovery lies, not in any randomized clinical trial.
Yes.
But unfortunately, that's a construct of the pharmaceutical industry. And they've transferred that to the medical profession very illogically. So unfortunately, like we're seeing with the vaccines, it's a comment that sounds crude, but doctors have been well trained by the pharmaceutical industry over the past 50 years on how to shine shit. And that's what they tend to do.
Yeah.
Yes. Yeah, we have to have the ability. Most people do not have the ability to set priorities. They're chasing everything at the same time. It doesn't make any sense. You have to set priorities, and the most important priority that we can see right now is probably the spike protein. Many of the other things may be worth chasing as well, but not now. Let's first go for the real danger that we can see. I think that's the most important thing, and that's the most important thing for people to understand.
Rainer, that is the focus of my work right now. COVID is no more a challenge. I don't have patients that demise anymore from COVID. But the spike protein is what's going to cause all the pathology I'm expecting to see over the next 5 years. And so the understanding of that spike protein and how to negate its effects is going to take center stage, whether we like it or not. But unfortunately, this is man-made. Remember that the only way to have been exposed to spike protein prior to vaccination was through exposure to a coronavirus. And when you got that virus and got over that infection with early treatment, you would now be immune to the vector, coronavirus. And so being immune to the vector would prevent you being exposed to spike protein in future, because the vector can't get into you. Unfortunately, now we vaccinated a large proportion of the planet, and that large proportion is walking around with spike protein. And so they are the new vectors of spike protein. So I guess the vaccinated are now the new coronavirus that's exposing us to spike protein. And so we're going to have this long-term exposure, and the understanding of its biologic effects, short and long-term, is vitally important. The diversity of what we see with spike protein is mind-boggling. I don't think that there will ever be a pharmaceutical intervention that's going to solve this problem, simply because pharmaceutical interventions are far too narrow in their target. The diversity of injury that we see requires products or chemicals that have a broader diversity of action and have the ability to get the body to self-correct. I, as a doctor, would not be quick enough to tell you what's wrong with you when there's this diversity of things happening in your body. But I'm sure your body knows what's wrong. So the nutraceuticals are going to prove to be the next big thing, in that if we understand their biologic effects and how they will influence the pathways that spike protein damages, they would be the next best thing in trying to solve the problems with spike protein. And that is the kind of research I'm being involved in with a few researchers and pharmaceuticals around the world to try and figure out the right mix that would actually help us negate the effects of spike protein. But it's a difficult task in that if the poisoner realizes that we can fix his poison, then he might change the poison. And if humanity stops deliberately poisoning itself, it makes my job that much harder. So, yeah, tough times.
Yes.
Okay. Well, again, I can't thank you enough, Shankara. As I said, this is the first time I really have an overview of what's going on. I can see all the little dots and I can even connect them from this medical perspective, which makes it a whole lot easier for me to analyze it in a legal manner. I think we are, because this is always the most important thing for a lawyer, to find out what the real facts are. You don't learn that at law school, not in Germany. You do learn it in the Anglo-American system, but not here. But your lecture gave me a huge step forward in that direction, getting all the dots connected so that we have the real facts, which we have to then analyze in a legal manner. Thank you very much again, Shankara.
You're most welcome, Rainer. And if there's anything I can help with, please, I'd be more than willing.
We will definitely
Thank you very
stay
much.
in touch, because I think there's going to be more to talk about very soon.
Yeah, you're more than
Okay.
welcome. More than welcome. Thank you.
Thank you.
Thank you.
Thanks so much.
And have a great
Thank you.
weekend.
You too. You too. I'm going to have a busy one.
Thank you very much.
God's delivered Omicron for my Christmas, and the world wants to know what's going on. So I guess I got my Christmas cut out for me.
Yeah.
Enjoy. I wish you well.
Bye-bye.
And
Yeah, thank you. Bye-bye.
Bye. Bye.
Thank you. Bye-bye. Yeah.